Okay. So for about next 45 minutes, I'll be taking you through few basic aspects of caring for palliating patients at home and how to address family and caregiver needs. So outcomes for this session are how we take home as a clinical setting, how we evaluate and manage patients at a community setting, how to provide end-of-life care, home visits, and how to evaluate and address family care needs. Now, I'm not going to go into very much details about the things that you all have done so far, that is how to evaluate patients, how to manage symptoms and things, but I'll be touching upon these aspects on a community perspective when the patient is not in an inward setting, when they come as outpatients, or when you go to visit a patient at home, how to deal in these situations. So, home for many of us is the best place to live as well as to die. So, in our country, why we should really concentrate on providing palliative care at household setting is mainly we do not have much facilities to uh, care for our patients in inward settings. I mean, imagine the number of patients undergoing palliative care. And if we are to provide institutions, where are we going to keep them? We don't have hospitals, we can't accommodate them in the hospitals, or we don't have hospice like institutions dedicated to care for palliating patients. So, most of our patients, even at the moment, are palliating patients are at their households. So who is going to look after them? For each and everything now, they have to go to their main caregiver unit, maybe a base hospital, maybe a cancer hospital, or maybe a teaching hospital, bigger hospital. Hardly our patients come to medical officers in smaller hospitals or their GPs. So we need to change this because otherwise our patients are suffering. So patients will find it very convenient if their closest doctor is eligible or can provide the care they need for non-emergency. I mean, most of the palliative patients, most of the situations, scenarios can be managed by a medical officer who is trained to provide palliative care. So, therefore, we need to empower the community level care, not only actually the medical officers, but I'll be talking a little on that, the nurses, other uh, ancillary or allied staff who will be helping us in this process. Okay. So we have some advantages in having patients at home. They are familiar with the setting and they feel very secured at a household. We can control physical environment to suit the patient in a household setting. I mean, in a patient who is in a hospital, they can't demand too much noise, too much light. Can you reduce this? I mean, things like that. It's very difficult to arrange to suit the patient. So, at a household setting, they feel like, they have a better quality of life. They can act according to their needs and wishes, and they can always be with their loved ones, so they will feel better. And also, not only the patient, there are advantages to the family also. It's convenient. I'm just imagine having somebody in a hospital. They have to visit the patient 2-3 times a day, take meals, go, come, and their routine is disturbed. So just imagine somebody in the hospital of your family, the hassle that you have to go through. So if we can care or manage these patients at home, that will be very convenient to the family. And of course, there are financial benefits, no charges for institutions, traveling, and things. And most of all, I mean, especially palliating patients who are spending their end of life stage, the family and the patient, for both parties, they can be with each other during the last time of their life. So that every moment of that time will be cherished by both parties in a comfortable, familiar setting compared to a busy hospital ward or for that matter, even inside an ICU. So the last moment spent in the family is precious to patients as well as to the family. So because of all these reasons, the home is a good setting to look after our palliating patients. So when we have a patient undergoing palliation at home, as medical officers providing care, we need to evaluate them properly to manage them. So evaluations are, some parts are similar to hospital evaluation, but some parts are not, because we need to have additional evaluation when we want to arrange care for them at home. So we need to be familiar with how to assess, how to manage symptoms, and when to do referrals, how to provide home care, like rather home visits and provide care in a household setting, how to mobilize whatever the facilities we have, maybe uh, we have social workers, community nurses, public health nurses. So how we can mobilize, or even volunteers, NGOs, how we can sort of get these people to facilitate care provision, how to provide psychological and spiritual support, and how to provide end of life care for good death. So, we need to be familiar with these aspects. And also, it's very important now in primary care aspect, we are not trying to treat patients, but we are trying to understand people who are having a problem. So it's not only the evaluation of symptoms, management of symptoms, but holistic approach. So how the patient think about this problem? What do they know? Now, to date, we have patients having terminal illness who are not aware about the disease. So if the patient do not know about the disease, we can't just go and openly talk to the patient about that. So before doing anything, we need to know to what extent the patient knows, what does this patient know about the prognosis, how long the patient has to live, or any idea about what's going to happen, because we meet, very often people with very unrealistic expectations because they don't have a proper knowledge about their disease. And what is the patient most anxious about? Whether it's dying, whether it's being disabled, whether it's being burden to the family, whether it's being dependent, or whether it's sometimes it may be going to the hospital. I don't want to go to hospital. I want to die at home. There are many patients we request from us, don't send me to the hospital. Whatever happens, that's okay. I'll be at home. So, and there are some patients who would say, I don't want to be dependent on the others, especially very strong personalities who had been taking care of the families. They don't want to be dependent among others. Now, I had a patient, whom I have been looking after for a long time. And then this patient got a oral CA, had to undergo surgery, had to be on an NG. And he didn't like it at all, because until that cancer, he did not have any other disease. He was the breadwinner. He was doing everything for the family. So he hated the scenario. And when I visited him at home, what he told me is, all along I have been avoiding Maria. That's how he referred. And but now I'm looking for him, but he's not coming. So indirectly, patient was indicating patient want to die, because the biggest problem was being dependent on the family members. And what is his biggest concern? Maybe a symptom like pain, constipation, or maybe I want to see my daughter before I die, who I have not seen in 10 years' time. So to make them happy, the last stage is happy, it's very important to understand our patients, their wishes, what they want in their rest of the, remaining time in their life. Okay, so this is patient assessment. I'm not going to go into very much detail. So you need to know the disease, control, what stage of the disease the patient is, where are the metastases, what are the complications already, what are the possible complications, what are the medications patient is taking. And medication review is a very important thing and essential thing you should do, because if we go through the list of medication of our patients, sometimes we see there are many unnecessary medications. Now, you have to tailor-made the medication to suit the patient's stage of the disease and maybe how long their life expectancies, everything we need to consider, and we should take away unnecessary medications, because the reducing number of tablets also means a lot when it comes to this this stage of care. And how to monitor? We need to monitor the malignancy or the condition they're having now. Maybe they're having other NCDs. We can't forget them. Patient may having diabetes, hypertension, any other, maybe cardiac condition. So how, other than these life-limiting conditions, other comorbidities also have to be monitored. Then in a community setting, how are we to arrange? So can we arrange a blood test? Do we have facilities to send testing via a government source, or whether there's a mobile lab close by? So we need to be aware about what to do in this scenario. And of course, symptom evaluation, whatever the symptom, you should be able to evaluate the severity of the symptom and also the impact of that symptom on the patient's quality of life, as well as among the family members and caregivers. For example, maybe patient has severe loss of appetite, and because of that, patient is not eating, and that is a very big concern to the loved ones. Dr. මෙයා මුකුත්ම කන්නේ මොනවා හරි දෙන්න බැරිද? සේලයින් එකක් දෙන්න බැරිද? So, in our culture, which is like very much food oriented, somebody withdrawing from meals is a very big thing. So, whatever the symptom, not only the face value of the symptom, how it is affecting the patient and the family. And there may be special needs, like patient may be on an NG tube, maybe on a peg, or a colostomy. So any special needs to this patient. So we need to assess all those, because we need to care for all those. And not like in the hospital, when we are arranging care at a household or community level, we need to assess activities of daily living and the instrumental activities of daily living. Is it possible to interact with the participants? Because otherwise it will be very... Can they communicate?
Yes.
Okay. So can someone tell like why it is important to assess the functional level of these patients? Now in the hospital, we don't do this much, but in a community setting, this is very, very important. Why?
We can make them engaged and that will make their life comfortable.
Okay, we can make them engage. If we know the level, things that they can do, then we can engage them in activities to make them happy and to improve quality of life. Any other important aspect? to decide on the carer needs. What are the things in the ADL? ADLs are the basic requirements of daily life, like mobility, whether they can walk, whether they can go to the toilet, dressing, feeding. So, I mean, if we compare a person who can go about, move around in the household to a bedridden patient, the care needs are so high. And if somebody can eat 3 meals, that will reduce the burden from the caregiver, because caregiver need not be there to feed that patient for 3 times a day, keeping everything aside. So uh, knowing the things that they can do and can't do is very important to decide on the level of care arrangement necessary. So if the patient cannot walk up to the toilet, we may have to think of providing a bedside commode or some alternative way of uh, doing the basic needs, because otherwise sometimes there may not be a person to take the patient or carry the patient from bed to the uh, toilet. And so therefore the level of functions. Okay, so instrumental activities of daily living are the things that they need to again spend their day-to-day life, things like shopping, uh, laundry, cooking, taking medications, handling finances, because all these things, the knowledge and their ability would help us in arranging a carer to provide care. Because now, of course, I mean, in Sri Lanka, these things are not happening much. But if we think of the West, now patients, most of the patients, I mean, elderly live alone. So when they can't do this IADS, they have people to go to their household, uh, do the shopping, cooking, and they store things at home and then come. So in that way, they can function inside the house, even though they can't do this IADS, they can function inside the household. So similarly, for us also, I mean, knowing these IADLs, the things that they can do would help us in arranging care. Then again, when we are assessing a palliating patient, we need to assess their psychological status, social factors, emotional, spiritual, I mean, it's holistic again. I mean, assessment we have to do. And it's very common to see depression and anxiety among these patients, because they know their life is limited. Some people are very anxious about what's going to happen, how they're going to die. And some people are, I mean, depressed, thinking about their children or family, things like that. So again, identifying and managing medically, I mean, pharmacologically and non-pharmacologically, would improve their quality of life. Then social factors like, I mean, the finances, can they afford their job, things like that. And the level of emotions and the spiritual needs again would help us in managing. I'm not going to go into details of these, because I'm sure uh, several times people would have touched upon these things. But I'm trying to emphasize is, even at a community level, at a household whole level, we have to consider about these aspects also. So how can we help this patient? Most importantly, managing symptoms. So pharmacological and non-pharmacological. I mean, for a breathless patient, just improving the ventilation by opening up the windows and getting a proper airflow through the room itself would relieve symptoms to a certain extent. So it's important that you know these non-pharmacological measures uh, in managing symptoms, especially at a household level, it would help. And how to monitor disease condition, the parameters, what to monitor. Now, for example, if a patient is having bone mets, we know their level of calcium can go up. So when they develop symptoms, then we need to have facilities or knowledge that we need to monitor this. right? And also you need to have an idea about the symptoms that can be managed at community level and the things that need to be referred. Now, pain due to bone myths we know can be managed very well by giving palliative radiotherapy. So that knowledge help us in referring patients to a proper care facility to get the radiotherapy done. And again, palliative care does not mean we are not going to refer patients or we must keep the patient at home and look after. It's not. If a patient is developing intestinal obstruction, then palliative surgery is still indicated. So you should be able to evaluate all the symptoms in that aspect. And what can I manage here? For what things I need to get opinion from somebody? Or what investigations do I have to do to identify the real problem? Or I can't manage, now I have to refer. So it's always important to do the timely referrals because, I mean, after a rupture of the intestines due to obstructions, I mean, the outcomes are very poor. Whereas if we refer in the very early stage, sometimes in a hospital setup with the IV fluids, nearby mouth and things, they may be able to even manage conservatively. So therefore, it's very, very important for you all to know or identify these symptoms and identify the referral points at a primary care level. And you have to have a very good idea about managing and maintaining devices. Again, I'm sure you may have had sessions on how to do a put a NG, how to check an NG tube, how to do a feeding and peg tube again, what to do if a peg is blocked, how to clean it up, uh, how to put a colostomy bag, I mean the base plate. So primary care doctors need to have a very thorough understanding about these palliative devices and the maintenance, I mean how to look after them uh, and identify the complications because sometimes pegs come out. So what to do then? Sometimes colostomies prolapse. Then what to do? So things like that you need to be familiar with. And addressing psychological and emotional issues, again, some people may need antidepressants. So we have to actually provide and we can provide. And some people become better with only counseling or some people we have to do both. And some have specific goals. I mean, we call different, sometimes we call bucket list or hope. I mean, there are foundations in other countries to sort of fulfill the wishes of palliating or patients with life-limiting illnesses. Unfortunately, we don't have such things, but still they can have specific goals in their life. Because when I was doing my palliative care, this master training program, there was a patient whose dream was to give a Buddha statue to the temple in his village before he dies. So a group of trainees, who are undergoing palliative, master training program, we got together and were able to actually send this Buddha statue and send pictures to him. He was so happy because that was his goal in life. So, I mean, there are things you can do, you can arrange. So that will really improve their psychological status during the last stage of life. So it's important to just inquire into these and then try to do, of course, you can't do everything. It's impossible. But whatever you can do, whatever you can arrange, would make a world of difference to their limiting lifespan. And similarly with spiritual requirements and legal proceedings, sometimes again, patients may want to do, family may want to do. Now, I have come across several instances, says family know that the patient is going to die and the properties have to be sorted, settled. they find it difficult to come into that conversation because they think අපි කිව්වොත් එහෙම හිතයි අපිට මේව ලියා ගන්න ඕනේ කියලා. So they don't want to initiate that conversation. So maybe you can be the mediator to start the conversation and to help both parties to sort the legal proceedings when they are conscious, rational, when they can sign. Or sometimes, again, we have to give letters. I mean, last week also I had to give a letter saying patient's intellectual capacity is good, but patient cannot use the hand due to the condition the patient is suffering, so cannot sign, but the fingerprint is valid. The patient understands the whatever is in the document after reading, so things like that. So you may have to get involved in helping this legal proceedings as well. And few words about end of life care. Very difficult, especially if you have been a physician caring for them for a long time. If you have been with the patient and the family for some time, then this is a very, very difficult task to open up and to continue this, I mean, bad news or the terminal stage. So how long this patient has. I mean, to say only few weeks, days, it's very, very difficult. And the family will be emotional. And you are close to them. You also tend to get emotional, but you can't show emotion. So it's a very, very tough situation, right? So for that, you need some practice or exposures to do these things. And withdrawing, withholding medication, hydration, again, as I said before also, the moment they know like patient can't eat and things, so they get really anxious, scare the family members. It's a very common situation there. They come and ask, Dr. මොනවත් කන්නේ බොන්නේ නැහැ. සේලයින් එකක්වත් දෙන්න බැරිද? How would you respond? You know, patient has maybe a day or two in life. What would you do? Yes.
We had a habit of giving saline, but I think now we have to change that.
Don't change your attitude, because we know overhydration can cause problems closer to death, like death rattle and things. But just to satisfy the family, giving a slow drip wouldn't harm them. I mean, if you can convince the family saying, this is the stage, then now it's very, I mean, the time is closer, so whatever we do may not help the patient and we don't want to prolong unnecessarily, you can have all your talks. But if you still feel from their bottom of heart, they think, "නෑ මොනවා හරි දුන්නා නම් හොඳයි." I mean, because the family will live with guilt, thinking like we couldn't do anything at the last moment. So if you feel that, even a slow drip won't prolong their life for sure and won't aggravate their symptoms. So still, so don't be disheartened. You can still do it, but I mean, not to, of course, I mean, we are not doing proactive things to prolong suffering. So motto of palliative care always has to be not days for life, but quality to days. So we are not going to do anything to prolong suffering. But if we can sort of make people, I mean, happy or consciously, they will not feel guilty by doing things, you may still do whatever, not inappropriate things, but of course you can give a bit of a saline, slow drip wouldn't do any change. And preparation of patient and family for death. So, I mean, who want to be there? Because sometimes it may be difficult, especially now this is a very big problem we see in our country, because we have probably, I would say, zero facilities at the community level to manage the end stage, last few hours of a person's life. Because if we can at least arrange some oxygen, morphine, subcutaneous injections, things like that, so the patient would be sedated, given some oxygen to comfort, then it will be a peaceful death. But if not, it would be an agony to the patient as well as to the people who are witnessing that, and that would be a very bad memory at the last stage. So, knowing there's no, better outcome, sometimes we are pressured to, or we have to refer some of our patients at the very last stage to the hospital just to make sure they are comfortable and they are not in agony at the time of death, right? So these are some things probably we can do at community level to enhance care. Maybe I'll discuss a little in the last slide. So an unfinished business like legal things, spiritual things, whatever the things the patient want, whether we could arrange them at the very last few days or hours. And the care is mainly comfort care, right? So relief symptoms, we are not thinking of addictions, we are not thinking about side effects and things at that point much. So pain-free, and very important to make sure bowel bladder issues are sorted, because otherwise those will be very, very uncomfortable to patients. And whatever they like, patient may have diabetes, but you are not going to restrict their favorite food because that's sugary, thinking of diabetes. If the patient is not going to go into coma with your food, might as well give, because we know they will not live to develop complications. So not only at the end stage, in palliative patients, you can always have the lifespan, having a little bit high sugar won't cause much harm, because they will not live to develop the complications. So let go. Let them have whatever they like to have, comfort care, comfort food, right? And we need to help them die peacefully. So, and pleasant environment, clean room, proper ventilation, and ability to interact with the family. So get the family to be around if they are conscious. That makes a very big difference, right? And whatever patient prefer, easy to eat, digest, if they can take, that's what we are giving, not a proper meal, right? And adequate amounts of fluids, not overhydrating, not to keep the patient dehydrated, because dry mouth and things are also very uncomfortable, right? So you need to know the balance, right? So for these, actually, that's why, we should have people to visit these patients who are at the end of life stage. May not be a medical officer. We can train a nurse really well to evaluate and manage this type of scenario. Right? Cleaning the patients, because we can't just forget, okay, they are dying. We need not be washed, mouth need not be clean, and things like nothing like that. Until the time of death, they should feel that they are clean, they are looked after properly, and minimum symptoms at the time of death if possible, right? And quality time with the family. So a little bit on home visits. If we do home visits, we can facilitate better and cost-effective care. And we can, sometimes there are unmet needs we can find out and we can address. Better understanding about the patient's living environment, so we can provide solutions. Enhancement of doctor-patient family bond. This is, it is part of primary care. We really cherish those relationships. So this is a real, important aspect to, or way of we can strengthen this bond. And effective use of limited resources, whatever they have, we can use to improve patient care, and time to understanding and addressing the care needs. Because if they visit your surgery, I mean, we will look at the patient, but not about the carer. We don't have much time to give for the carer. But if you go to a household, definitely you would have adequate time to talk to the carer and to address their needs. Now, this I have put I think a home visit I did few weeks ago, where patient was having breathlessness and noisy breathing due to secretions. And there was no way to sort of elevate the patient's, head side. This is what we did, right? This is a very common thing actually we do, very easy thing. You get a chair, and this is how we place the chair so that it gives a nice angle. So it's really a typical propped up patient we have. And so the moment we did this, the secretions sort of noise cleared, patient was breathing very peacefully. And after this, after about maybe 2-3 hours, patient passed away. And that daughter was so grateful. She was saying, because you did this, patient did not have even a noise at the time of the death. Just patient has passed away peacefully, where she had been struggling for breath, with the noises for last couple of days, right? So, simple things can make a huge difference to the patient as well as how the family perceive it. And by going, you can't, do this, or you can't even imagine how to do this if you are at your surgery. So you have to visit the household, you have to get hold of whatever is available, and then provide care. And when you have to do a home visit, you need to see what are the objectives. Am I going to do a wound dressing? Am I going to do a catheter, put an NG? So we need to look at the patient's records and see the conditions patient is having. If the patient is having blood sugar, you might as well grab your glucometer and go to just to check the blood sugar, because you're going there. So you arrange a time with the family. And of course, earlier, those days, doctors used to have a huge bag to carry to households. But we don't have such a thing, but we get whatever the things, depending on the purpose of the visit, to assess and manage the patient that we are, wherever we are going. So when we go, we not only assess the patient, but we assess the carers as well as the environment. So again, it's basically the same things. We do assessment of patients with history examination. And we need to look at bed sores, oral cavity, swallowing, especially patients with dementia. They stop swallowing. They keep food in the mouth. And when they swallow, they get aspirated. So you need to evaluate swallowing. You need to know how to do it, and you can advise the family on how to do a proper feeding at home. And then sleep, nutrition, feeding, psychological, social, spiritual aspect, medication, always it's a must. You have to go through the medication and remove unnecessary, and evaluate the support given to the patient, with this adequate, not adequate, need modification, things like that. And again, this is the same patient, environment, whether it's clean, whether there are risks to falls, any dangers, whatever the patient can injure, and whatever the facilities the having at household, you optimize your care by utilizing the facilities, whatever is available. Now, for this patient, there was no saline stand. If you can, I don't know whether you can see the top part of the saline bottle is not there. The saline bottle was tied to the window frame, this kuru thing in the window, the grill, and that's how the saline was given. So an opportunistic evaluation means sometimes there may be unsafe things. Patient may be taking medications, including morphine and things, and there may be children at household. So you have to advise them about safe keeping of medication and things like that. You take the opportunity to improve the care as well as improve the health of the family. And care and carer, both aspect we need to see, because sometimes all are not loving, caring. Rarely we see abuse, neglect, right? So you need to be very sort of observant and sort of be suspicious, or not really suspicious, but open to appreciate whatever you. Sometimes you, when you go, you would see bruises in the patient. If the patient is not having any bleeding tendency or anything, then it may be due to rough handling, right? So you, I mean, you can, if you observe such things, maybe you can advise on how to handle patients and things like that. And we need to ask from the carers about their problems, what they are going through, and evaluate the needs. Sometimes they need training. They request, doctor මේක මට පුරුදු කරන්න පුළුවන්ද? Or they may need support because they can't manage alone. So as the physician in the community level, the person who knows the family, you are the best person who can arrange this support system, because you may know the extended family, you may know the neighbors, you may know whoever is in the village who would come and help. So you, I mean, as the doctor, if you initiate, then that could be convenient to the patient's family as well, right? So carers, families have many issues, right? Especially now, palliative care, we are not talking about caring for a week or two. We don't know for when, sometimes maybe for years. So who is there to look after these patients? Because family members, they may have other commitments. So you need to see who is there to provide care. Then what are their abilities and what are their training needs? Are they exhausted physically, psychologically? How to prevent and how to manage, both you have to think. The emotional level, especially if the the bond is very much with the deceased person, then they will have a lot of emotional issues, right? And also when we, it's a very common thing, I mean, now it's would be much more the financial burden when we have a palliating patient at home, because there are a lot of needs, maybe medication, equipment, even a pamper is very expensive. So how to help or how to support them, right? And social implications also we have to look into. So arranging carers, it may be family members, it may be relatives, or there are trained carers. So things like, I mean, HelpAge would, like NGOs, they have trained people, or private, I mean, famous is Sada Saran, and the places are there. But they're very, very expensive now. So affordability is a problem. So, I mean, then what, right? So there may be volunteers, right? So if we cannot arrange any of these people, there may be volunteers who would take turns and look after the patient. So this is a problem and will be a bigger problem in the future, because now we see a lot of young people are migrating, and elderly people are at home, they are with NCDs, they are with the terminal illnesses. So who is going to look after them? Arranging care would be a very major issue in the near future. Then training needs. Now, this is another very important aspect. I mean, if you have a hospital attachment or hospital-based training, I mean, please make sure you pay some attention to learn these things, because when you visit a home or when you want to train a person, you should know, you can't tell, you have to train. To train, you have to know how to do things. So, I mean, how to clean a patient, how to give a bed bath. I mean, I'm asking this from many trainees who come to me, including palliative care diplomats, and a lot of people are not sure or not really aware about how to give a bed bath to a patient, which is very important when we have to manage a bedbound patient, right? And then how to give oral care, how to give eye care. So if you have a hospital attachment, best place to learn is the ICU. I mean, a simple thing like how to make a bed properly without a rally, because those things are I mean, increase the chance to get bed sores. So the sheet should be properly tucked in. So how to do that? Simple things, but important things when it comes to looking after patients at a household. Then you have to have some idea about nutrition. I mean, not to do nutrition diploma, but basics. The how to make a nutritious meal, condensed meals, where like for patients who are not taking much, you need to give all the nutrients in a small condensed meal, and the things become even worse if the patient is on an NG or a PEG, because we need to prepare whatever the food which could be given through the feed and through a tube, and the tubes, when we feed through tubes, again the quantities are very small. So how to make a nutritious meal, or a small meal with all the nutrient requirements? So you have to have some idea. And how to measure input output, so you have to teach them how to look for dehydration, overhydration. So because now when you keep the patient home, caregiver is the person who is going to look after, identify things and report to you. So unless you teach them the things to look for, they don't know, right? So therefore make sure you train them in sort of doing, I mean, evaluating danger signs as well. How to give medication, uh, effects, side effects, and if they develop side effects, what to do, when to inform, right? And how to manage devices, as I said before also, NG, PEG, caring, managing, feeding, everything you have to know, because you have to train them. Or maybe if you're working as a team, you can get a nurse uh, trained in managing devices. And again, another very important thing is the tracheostomy, right? So those things are important to learn how to manage. And also you need to train them on recognizing the danger signs depending on the condition the patient is having. Some may develop abdominal distension, some may develop SVC obstruction, some may develop intracranial bleed. So whatever it is, depending on the condition, you have to look for these things. If the patient has any of these, please inform me or rush the patient to hospital. Sometimes we have to tell that also, if we know patient is at risk of developing medical emergencies. And importantly, how to prevent bed sores. So turning and maybe utilizing commonly available things like gloves to sort of alleviate pressure and things are very important. And if we think of the carers, they are caring over a long period of time, and there's high chance they can become exhausted, right? So then what are we to do? How we can arrange support for these people? uh, how can we give rest, and how to advise on proper handling so that it would prevent the physical exhaustion of these patients, right? So there are some respite care facilities, not very common, but at least maybe relatives support, I mean, friends, volunteers, somebody can come and give a break to these carers. That is very important. And if we teach them how to lift a patient, how to turn a patient, that will prevent them injuring unduly. So it's very important. Then addressing emotional and social issues. So someone to talk, maybe for them to get rid of their emotions, feelings, then support systems, emotional, financial, I mean, it's available sometimes. Financial things, you as a doctor, if you recommend, they can get some financial assistance. And it's very important to educate and counsel about the disease and expected prognosis, because they know what to expect. They don't have undue expectations, and psychological preparation for death. So identify who is going to get affected by the uh, demise of this patient, and how they are going to cope. You have to encourage whatever their coping abilities to practice them. And if we discuss about the care plan, what to expect, then they will be relieved for to a certain extent, and how the patient would die, and you have to ensure you are there during the bereavement as well, not only until the death of the patient. So there may be cultural factors influencing carers, like, whether they want to take our advice, whether they are complying instructions. Because of the interest of time, I'm not going to go into detail, but there are very many examples how they refuse or how they do not want to do different things based on their religious and cultural beliefs. So, a lot of challenges. The biggest, I would say, is there's no team. So it's sort of single-handedly, if a doctor is doing, they have to do it, which is not practical. It's not doable, actually. And we don't have a proper back referral system. If we had a good referral system where the caring physicians send with all the details, these are the medications, this is what to do, this is when to refer, and things like that, that would be very easy to the doctors at the community level. No facilities, especially as I said before, also oxygen, medications like morphine are not freely available. And the time, who is going to go? How are you going to devote time to do a home visit amidst your all other busy schedules, right? And sometimes there may be interferences and demands from the family. Why not you do this, doctor? Why can't you do this? They will come and demand undue things, or the things that you can't do, or things that have no use, but it's very difficult to convince the patients. And the legal aspects, like your Dr. Professor Pandaka discussed before, the advanced directives, DNRs and things like that. So how can we make it better? We need to empower the primary care team, like you're training doctors, nurses, volunteers, and formulating multidisciplinary teams, if possible, including physiotherapists, occupational therapists, maybe psychiatrists, or at least a mental health to support these people. Proper referral system with clear instructions, and improving communication with patient, family, and caregivers. Access to essential medication like morphine, oxygen, and working in collaboration with families so we can educate them on identifying and managing symptoms, and supporting through death and bereavement would really ease your duties. And arranging commonly needed equipment like bedside commode, air mattresses, wheelchairs at a central point. Maybe if you are at a divisional hospital, you can lend them. We are up to date. We are doing this. We are lending it to the people who are needed, and then they return us usually after the death of the patient, so that they need not spend on these things. And any system to get basic investigations done, maybe a blood collecting center, or somebody to go home, collect blood and get the investigations done when necessary. So if we can arrange few things at a community level, that could really improve the care a lot.